Menstruation is the final, synchronized step of a complex hormonal cascade. When that flow halts, it signals that the underlying systemic machinery has failed. Amenorrhea is a clinical endpoint. Rather than a disease in its own right, it is a symptom of a disruption somewhere within the reproductive system. We define primary amenorrhea as a patient who has never reached menarche. This is typically typified by an 18-year-old woman who has never had a menstrual period. Secondary amenorrhea is the cessation of menses for more than 6 months in a woman who previously maintained a normal cycle. Establishing which of these two timelines the patient fits into is the mandatory first step that dictates the entire diagnostic algorithm. This diagram shows the hypothalamus-pituitary-ovary axis, the physiological feedback loop that governs the cycle. It begins at the hypothalamus with the release of GnRH, or gonadotropin-releasing hormone. GnRH stimulates the anterior pituitary gland to release two key gonadotropins, follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. These travel to the target organs, the ovaries, stimulating them to produce estrogen and testosterone. Disruptions anywhere along this chain, whether through anatomical blockages, receptor failures, or hormonal suppressions, result in amenorrhea. To reach a diagnosis, the clinician must trace this axis backward to identify the specific anatomical or chemical point of failure. The first major clinical fork in primary amenorrhea is checking for secondary sexual characteristics, like breast development. This decision tree shows the path for a sexually infantile patient. The diagnostic direction depends on the patient's physical stature. Short stature strongly points towards Turner syndrome, a 45XO chromosomal profile characterized by non-functioning streak gonads. Specific physical markers accompany this condition, including a webbed neck, a wide carrying angle, a bicuspid aortic valve, and a horseshoe kidney. This image shows question OGQ63, where primary amenorrhea is linked specifically to Turner syndrome as a common clinical finding. If the patient exhibits a normal physical stature, the differential shifts toward Kallmann syndrome, a form of hypothalamic hypogonadism. Kallmann syndrome results from a GnRH deficit and is uniquely associated with anosmia, a lack of smell, and potential color blindness. In sexually infantile patients, systemic signs like height and the sense of smell often indicate underlying genetic or central nervous system failures. This 2x2 grid maps physical findings against anatomical imaging for patients who present with normal feminization. The quadrant for patients with both breast development and a uterus includes pregnancy, a transverse vaginal septum, and an imperforate hymen. An imperforate hymen manifests as recurrent cyclical lower abdominal pain, often accompanied by a suprapubic mass. Patients with breast development but no uterus are categorized under Müllerian agenesis or androgen insensitivity syndrome. Those with a uterus but no breast development point toward gonadal dysgenesis, or broader failures in the hypothalamus-pituitary axis. Mapping physical exams against a basic anatomical ultrasound categorizes complex primary amenorrhea cases into distinct clinical brackets. Secondary amenorrhea requires the immediate exclusion of pregnancy and menopause. Beyond those, we look for systemic metabolic disruptions, uncontrolled diabetes mellitus, renal or hepatic failure, and thyroid dysfunction. Severe environmental stressors, such as eating disorders, emotional stress, or strenuous exercise, can also induce functional hypothalamic failure. At the pituitary level, hyperprolactinemia, often caused by a microadenoma, suppresses the entire axis. Pituitary disruption also occurs in Sheehan syndrome, which is the necrosis of the anterior pituitary gland following excessive blood loss during delivery. This presents as agalactorrhea, the absence of lactation, alongside signs of adrenal and thyroid insufficiency. Secondary amenorrhea originating high in the axis usually points to a severe external stressor or a systemic shock to the brain's control center. This table compares the hormonal profiles of polycystic ovary syndrome, or PCOS, and premature ovarian failure, or POF. PCOS is characterized by high LH levels that create a 2-to-1 or 3-to-1 ratio to FSH. This results in elevated testosterone and an ultrasound showing more than 10 cysts. POF shows very high FSH and LH with low estradiol. Patients typically present with menopausal symptoms within 12 months. This image shows question OGQ64, featuring a patient with amenorrhea and markedly elevated gonadotropins, which confirms a diagnosis of premature ovarian failure. At the uterine level, Asherman's syndrome is caused by intrauterine adhesions, often following a DNC procedure. Localizing these lower axis defects requires analyzing hormonal ratios and checking the patient's surgical history. This flowchart illustrates the step-by-step pathway for evaluating amenorrhea. Step 1 for any patient of childbearing age is a urinary pregnancy test checking beta-HCG. For primary amenorrhea, Step 2 is an abdominal pelvic ultrasound to verify the anatomical presence of the uterus and vagina. It is a critical clinical constraint that a pelvic or vaginal examination must not be performed on a virginal patient presenting with primary amenorrhea. Step 3 is the hormone panel, measuring FSH, LH, prolactin, and estradiol. Low FSH and LH levels indicate hypothalamic or pituitary failure, while high FSH points to POF. High prolactin indicates a prolactinoma, requiring an MRI. This lab-based algorithm ensures no diagnosis is missed while protecting young patients from inappropriate physical exams. Amenorrhea is a symptom of a disrupted axis, not a standalone condition. The first step is to use patient history to separate primary from secondary timelines. Primary amenorrhea is categorized by mapping physical characteristics against uterine anatomy. Secondary amenorrhea is evaluated by tracing the HPO axis from the brain down to the uterus. This algorithmic approach organizes complex clinical presentations into a repeatable, logical sequence. By following this structured diagnostic algorithm, clinicians can confidently navigate the complexities of amenorrhea. Thanks for watching Insight Engine. Subscribe for more clinical breakdowns.